Breast cancer is the most commonly diagnosed cancer worldwide after skin cancer and the second leading cause of cancer deaths in women. Black women are 40% more likely to die from breast cancer. And all of us know someone who has been diagnosed with breast cancer. And for many of us, that person is a family member. Dr. Lisa Newman is an internationally renowned breast cancer surgeon and researcher at the Weill Cornell Medical Center in New York City. Her research focuses on health disparities and researching genetic markers for women of African descent. We were going to be discussing the common misconceptions about breast cancer, who should get genetic screening, and when and how often to do screening mammograms. This episode was brought to you by Alloy Health and Rivian. You know that game, 6 Degrees of Kevin Bacon? Well, if you're a Black person in America, you don't need 6 degrees. You only need like 2, maybe 3 degrees, and we can pinpoint ourselves in time. And I am so delighted to be joined by Dr. Lisa Newman. We go way, way, way back. Lisa and I were both classmates of Harvard, class of 81. And to make that circle even tighter, I actually met your sister a long, long time ago. So it is a small, small world.
Yes, it is.
Yes, it is. And I want to welcome you to the Second Opinion. We've got so much to talk about today, and I'm really, really, really excited to have this conversation. But, you know, what comes to mind is it's just a couple of days ago, almost exactly 5 years to the date, you know, I lost my sister from breast cancer. And you and I sort of share this horrible history that, I think it was in 2020 that both of us lost our sisters to breast cancer. And in the case of my sister, I think what made it even more tragic was not just the fact that she died of breast cancer. She died of the fear of breast cancer because we come from a very, very, very cancer-laden family. And so she knew that. And, you know, it will forever haunt me as to why, knowing what our family history is, what it is, that she did not avail herself of screening mammograms. And at best I can tell, Lisa, I don't think she had had a mammogram in at least a dozen years. And that's a story that I think is important for, all of our listeners to hear, is that it doesn't have to end this way. But I know that you also have a story about your sister. Would you mind sharing that with us?
Yeah, no, absolutely, Sharon. And again, I thank you so much from the bottom of my heart for doing this. Your show is so incredible. Congratulations on your success with this effort. What you're doing is so important in getting valuable messages out to the public regarding how to protect our health. And I did tragically experience a similar loss as to what you explained. My fabulous, vibrant, wonderful sister who had so much left to do in life, had already been so incredibly active as a prosecutor in the U.S. Attorney's Office for most of her career. And then when she stepped back from that role, she took on a whole new career as a teacher in the New York City public high school system, teaching kids that were very disadvantaged in many ways. So much left to do. And she didn't even have a chance to fight her cancer off. Her breast cancer presented with neurologic changes from brain metastases. And it was one of these incredibly virulent patterns of triple negative breast cancer, an inflammatory version of triple negative breast cancer that hit her, and in hitting our wonderful sister, hit our entire family like a sledgehammer. And tragically, because it was so advanced when it hit her out of the blue, we lost Debbie in about 2.5 months.
And I think that this is really a good point for you and I to sort of share with our listeners that there really are. It's not, breast cancer isn't one disease. There are several different types. And would you mind just sort of letting our listeners and viewers know what are the types of breast cancer and why one is so aggressive versus the other?
Yeah. So, Sharon, you made such an incredibly powerful point just then. One of the most influential groundbreaking advances in cancer research over the past few decades has been the recognition that breast cancer is not just one single disease. It's actually comprised of an entire spectrum of different subtypes. And these different subtypes have specific tumor biologies, degrees of aggressiveness, and different treatments. Now, most women with breast cancer will require some surgery because you do need to control the disease in the breast. And that's where somebody like me, as a surgical breast oncologist, comes into the picture, controlling the disease in the breast with operations like lumpectomies or mastectomies. However, the majority of breast cancers have actually already spread through the bloodstream before we've even diagnosed them. And you have microscopic amounts of those breast cancer cells hiding in the liver, the lungs, the bones. And those are the breast cancer cells that we have to worry about the most, because that's the disease that can turn into metastatic or stage 4 breast cancer. Since, however, we have generated so many wonderful medical treatments that we can give women when they're first diagnosed with a breast cancer, these medical treatments will obliterate the microscopic breast cancer cells hiding in other organs, and they prevent the high majority of our patients from ever developing metastatic breast cancer. But you do want to make sure that you tailor those medical treatments to the individual characteristics of the cancer. And this is what we call precision medicine or precision oncology, being able to focus the treatment on the type of cancer. And that's why your point about different breast cancer subtypes is so very important. This is the key to best successes in treating breast cancer.
So we've had the most success with, and I don't use this term really blithely, but when I say garden variety breast cancer, that is the type that is most common, and that is. Could tell us a little bit about what the treatment is for an estrogen receptor positive or a progesterone receptor positive cancer, because the difference in survival really depends on whether or not you are lucky enough to have the common one or unlucky enough to have the more aggressive type.
Yeah, absolutely correct on all points. The first step in precisely characterizing a breast cancer subtype is related to the original biopsy characteristics. And the first characteristics that we look for on any breast cancer biopsy specimen are things called the estrogen receptor, the progesterone receptor, and a protein, which is a growth factor protein called HER2/neu. The cancers that are positive, the cancers that are overproducing these hormone receptors, estrogen receptor and progesterone receptor, they are indeed the most common forms of breast cancer. They account for about 80% of the breast cancers that we diagnose. And because they are so very common, we've developed many different medical treatments that can target these hormone receptors. These are what we call endocrine treatments for breast cancer. And often these endocrine treatments are in the form of pills that women will take, one pill a day for several years. And this, for many women, can be perfectly adequate in successfully conquering that cancer and preventing the woman from ever developing metastatic breast cancer. Sometimes, however, we do need to use chemotherapy, and chemotherapy does have many more side effects compared to the pills. We've developed other targeted treatments that focus on the third marker that I mentioned, HER2/neu. And these anti-HER2 treatments are very, very successful at obliterating the cancer cells that overproduce this growth factor receptor. The cancers of the breast that are what we call triple negative, the ones that don't express any of those proteins, are the ones that tend to be more biologically aggressive, in part because of the fact that we don't have targeted therapy for these triple negative breast cancers. And so we need to rely on the more generic chemotherapy to prevent metastatic disease from triple negative breast cancer.
There's also, and I think this is really the foundation of a lot of the research that you've been doing, is about the different ethnic groups and how it affects Black women differently, the type of breast cancer that they get, and ultimately is a problem for prognosis, right?
Absolutely. And yes, the bulk of my research over my career has been in looking at variations in the breast cancer burden related to race, ethnicity. And one of the most stark or largest magnitude differences in breast cancer outcome is related to being African American women compared to white American women. And the death rates from breast cancer are 40% higher in Black women compared to white women. And this is partly attributed to the fact that as African American women, we have a twofold higher risk of these biologically aggressive triple negative breast cancers. And so some of the difference in outcome and these disparities are related to the biology of disease that's more common in Black women. Now, disparities in breast cancer outcome are also related to socioeconomic issues and, tragically, lack of insurance and just being under-resourced in terms of being able to receive the appropriate medical care and having delays in medical care. These are all problems that are disproportionately seen in the African American community, and those social determinants of health and disparities also play a large role in outcome disparities related to African American ethnicity.
I think one of the things that was most disturbing to me, when reading about breast cancer and delving into it, is finding that even when Black women have the good prognosis type breast cancer, even for all of the positive factors that it could be, they still do worse. And, it appears that it's not because it's necessarily the tumor biology. It's not that. It's, again, having insurance, having a ride, having access to a comprehensive cancer center. Do you have babysitter, paid time off from work?
Yeah. You're so right there. Yeah. It's wonderful that we've made so many advances in taking care of breast cancer, and women have so many options. But taking care of that breast cancer successfully relies on early detection. So you have to have access to screening programs, and then you have to act on any abnormalities that are identified. And that action needs to be in a timely fashion. Black women are tragically more likely to undergo their screening mammograms in facilities that don't necessarily have the highest quality equipment. We are more likely to have delays in a diagnosis once an abnormality is detected. And then once a cancer is found, we are more likely to have delays in initiating treatment and completing treatment, because that treatment in and of itself is a huge commitment. It often requires combinations of not only surgery, but radiation, sometimes chemotherapy, other medical visits to coordinate some of these medical treatments that we've been talking about as part of precision medicine. And all of that is time consuming, and it can be quite a burden in a woman that has socioeconomic disadvantages and many other obligations related to family care, professional obligations that just are not conducive to getting that treatment in a timely fashion.
The whole history of how we approached breast cancer has changed dramatically. When Lisa, and I'm sure you know this too, when I started practice, I had patients that had radical mastectomies. And when I say radical mastectomies, that is the surgery where they basically take you down to the bone, basically, in an attempt to eradicate the breast cancer. And I think that this plays very heavily into the outsized fear that women have of breast cancer, is because it was a horrible disease.
That does remind me of medical school days. I can remember the routine where a woman, if she had any lump in her breast, anything that was suspicious for a breast cancer, she would be brought to the operating room, have a biopsy to remove that lump under general anesthesia. The pathologist, the laboratory, would look at that lump under the microscope while the surgeon was in the operating room with the patient under general anesthesia. If the pathologist called into the operating room and said there was a cancer diagnosis, the surgeon went on and did the full mastectomy. So the woman would wake up in the recovery room finding out that she had a breast cancer diagnosis because of the fact that her breast had been removed. And we look at it as being a horrific experience today, and fortunately those experiences are relegated to historic significance, but that's all that was available at the time. Today, fortunately, and you're right, what we do need to make sure the women understand today is that we have great ways of detecting breast cancers early, through screening mammography, through other ways of evaluating the breast tissue. And most women can have their breast cancers diagnosed in the form of a needle biopsy that's performed as an outpatient procedure. And then the results come back, and the woman has a face-to-face conversation with her treating team regarding the various options that she can receive to get that cancer treated appropriately. Now, sometimes a mastectomy is still necessary, but for those women who do undergo mastectomy, we have fabulous breast reconstruction options. Most women who undergo mastectomy will have breast reconstruction right at the same time as the mastectomy. We can usually do something called a nipple-saving mastectomy, where we basically preserve the entire envelope of breast skin, and the plastic surgeon fills in all that skin with whatever reconstruction the patient chose. And the majority of women can actually have breast-saving surgery, where they simply undergo a lumpectomy to remove the area where the cancer was found. And usually that lumpectomy is followed by radiation treatment to treat any microscopic cancer cells that are left over in the breast.
I want to get to something else, because I know it's always top of mind for patients as they're making decisions, and that is the role of family history. Mm-hmm. And I'll share with you a little personal information. In addition to my sister, who passed away 5 years ago from breast cancer, I have another sister who was diagnosed with breast cancer at age 37. I didn't know about my mother's aunts until they were, at their funeral. Now, they died at 94 and 84 of something else. And it's like, oh, who knew she had breast cancer? Which is why I tell people, please, please, please know your family history so you at least know what to look out for. But here's the question I have for you. Clearly, something's going on, whether it's environmental or a gene or something that's specific to our family. How would you advise somebody like that who has that sort of generational breast cancer?
People do need to understand their family history. You should know that family history on an extended basis on the maternal side as well as the paternal side. And you want to look at different types of cancers that might be in the family, not only breast cancer, but ovarian cancer, colon cancer, thyroid cancer, melanoma. All of these different types of cancers will often cluster in pedigrees where there is some hereditary predisposition. And today, the genetic testing often will involve a panel of several dozen different genes that are being evaluated, and abnormal patterns in these genes might pinpoint hereditary predisposition. But not all the time. As you stated, there are many families where there's clearly something going on of a hereditary nature, and even several dozen tests will be completely negative. So we haven't learned about the full spectrum at this point in time in terms of cancer risk. And that inadequate knowledge about the full spectrum of genetic cancer risks is more common in individuals with African ancestry.
Right.
The genetic testing just hasn't been done often enough in African Americans, so that we are more likely to have information that misses potentially important findings.
And that brings to mind, because here's my question about genetic screening, is that particularly in the United States, it's impossible to look at anybody and say, what their genetic makeup is. Look at you, look at me. Okay, well, we didn't directly come from Africa looking like this. So there's a lot of other stuff going on. And I guess my question to you, because it was a lesson learned for me, not to just automatically say, oh, well, that's not likely to be your story. Should we be doing a better job of not ruling people out, even for the genetic screening that we at least know what to do with?
There are mechanisms to protect yourself from the threat of cancer, certainly breast cancer and ovarian cancer, if you do have hereditary predisposition for those diseases. So having the information can absolutely be life-saving. If you know that you have hereditary predisposition, it can influence how you screen yourself. You will not only be getting the mammograms, but you'll start getting those mammograms at younger ages. You'll often get ultrasound, whole breast ultrasound in conjunction with the mammograms, and you'll probably qualify for getting breast MRIs on a regular basis to evaluate the breast. Some patients will go down the path of having a prophylactic or preventative double mastectomy to lower breast cancer risk. Some patients will be candidates to take special pills that can lower their breast cancer risk. So the genetic testing can serve an important purpose.
I agree. But I think but if you see someone who has generational breast cancer in younger women, I think that the message should be, don't be dissuaded from getting the testing because someone looks at you and go, well, you're Black, that you're not likely to have that. And I will be perfectly honest with you. Lisa, I wish I could say I was so smart that I figured that out. I did not. But this is the value of a second opinion. The value of a second opinion. Remember, we don't know everything. And when you don't, ask somebody.
Absolutely.
At Alloy, we firmly believe that given good information, women are more than capable of making good decisions for themselves. If you've had thoughts around menopausal hormone therapy, but have not gotten a recommendation from your primary physician, connect with one of the menopause-trained doctors at Alloy. Here's how it works. Sign up and personalize your treatment. Fill out a quick intake to share your symptoms and goals. Match with a menopause doctor. Connect with a board-certified doctor in just hours. Easily manage your plan. Receive a treatment plan tailored to your body, your symptoms, and your life. Care delivered to your door. Get your prescription sent right to your doorstep. I am proud that Alloy is the only company that connects women with doctors in all 50 states and DC. And you have the ability to ask questions to that doctor for the entire time your prescription is active. No extra charges. And guess what? It's available to you online. No endless waits for a doctor's visit or in pharmacy lines. Just relief and results delivered right to you. Join the 95% of women who tried Alloy and saw relief in the first 2 weeks. Head to myalloy.com and tell them all about your symptoms, and you'll get a fully customized treatment plan. And you'll get $25 off your first order today when you use code TSO25. Head to myalloy.com and enter code TSO25 to get $25 off your first order. Every Thanksgiving, my family and I pile into the car and head to my sister's house down south. It's a tradition that's as much about the drive as it is the turkey. We sing along to our favorite playlists and share stories about years past. When our kids were small, we could pile them all in the backseat of the car and take a road trip to spend Thanksgiving with family. When you have little people, you can put them all in one room. Now we have grown-ups and significant others, and that plan no longer works. This year, we're traveling to meet our newest family member, the first baby of the next generation. But this time, we need more room. That's why we booked a stay on Airbnb. Thanksgiving is the only holiday devoted to family, food, and the warmth of homes. And thanks to Airbnb, we'll have a beautiful home to make more memories and welcome our new nephew. As I look around at my family laughing in the car, I often think, while we're away making these memories, someone else could be creating their own special holiday traditions in my home. That's what I love about hosting on Airbnb. Your home doesn't have to sit empty. By opening up your extra space, you could turn it into a welcoming retreat for travelers from around the world, giving them a place to gather, cook, and make lasting memories of their own. And the added income? It could help fund future adventures, thoughtful gifts, or whatever else matters to you. Wouldn't it feel good to know your home is helping create holiday memories for other families? Your home might be worth more than you think. Find out how much at airbnb.com/host. This episode is brought to you by our friends at Rivian and their all-electric, full-size SUVs and trucks made for all of life's adventures. Rivian just announced their all-new Rivian Quad, their fastest, most capable vehicle yet. Powered by 4 motors, one for each wheel. It gives you unmatched traction, control, and performance anywhere you are. On winding roads or off-road trails, the quad is engineered for precision driving and maximum adventure. With a native NACS port, the quad is compatible with 50,000 DC fast chargers, so getting back on the road is hassle-free. With beautifully designed interiors, tons of storage, and incredible capability inside and out, the quad is made for everyday comfort and rugged utility. Plus, you'll love the tech. The Rivian experience gets better over time with software updates. The premium audio experience sounds as good as the ride feels. Premium audio is part of the Sound Plus Vision package in quad and tri vehicles and can be a paid upgrade in dual models. And the Rivian Autonomy Platform Plus, a paid subscription product, offers a full suite of advanced safety and driver assistance features. There is adaptive cruise control, active lane keeping, blind spot monitoring, and forward collision warning with automatic emergency braking. Check out the all-new, all-electric quad truck or SUV and the full lineup of vehicles now at Rivian.com. And let's just do a little level setting. We have more and more women now who are surviving breast cancer because they're diagnosed early. You get treated, you go on, you live the rest of your life. And, you're more likely to die of cardiovascular disease than you are to die of your breast cancer. Good news. But the pendulum has swung in the other direction. And I think it's probably this residual fear that we have of breast cancer. It's really put it in our hearts. But do you see that a lot of women are coming in asking for prophylactic mastectomies when they really don't have the level that would require it?
The short answer to your question is yes. I am seeing an increasing number of women that are exploring the option of prophylactic mastectomy surgery. And some of that, as you mentioned, is related to heightened awareness. Many women are advocating more forcefully for themselves, and they are aware of their breast cancer risk factors, and they want to do whatever they can possibly do to lower that risk of getting breast cancer. The double mastectomy is absolutely the most effective thing that a woman can do to lower breast cancer risk, but it's really important that these women understand that the prophylactic mastectomy does not eliminate the risk. When we do a prophylactic mastectomy, you can have microscopic amounts of breast tissue hiding right in the skin. So even after a bilateral mastectomy for prevention purposes, the woman does need to go in for yearly checkups to see if there's a nodule that develops in her skin representing a cancer despite that prevention mastectomy surgery.
So, and exactly. And I think you're right. We're seeing two different populations of patients. And see, my patients are the ones that are, that are kind of coming in and they may have a very, low stage, maybe a stage 1 breast cancer. And again, they're so fearful of it coming back. Even the reassurance of saying, again, we never say 100% anything, but the chances of this being a problem for you are low. And again, that fear is driving them to say, I don't want it. Just take them both off. And I'm like, that's, a little harsh, but I get it.
Yeah, it is. And I do get it also. But I think one of the toughest things that I face in clinic when I'm dealing with a newly diagnosed breast cancer patient is to stress to them the point that you made at the very beginning with regard to the different breast cancer subtypes and the fact that we've made so many advances in basically curing breast cancer or achieving the best survival rates with precision medicine. We are able to prevent metastatic breast cancer in the high majority of our patients, but preventing metastatic breast cancer is related to giving the proper targeted therapies to prevent metastatic disease. The double mastectomy does not contribute to that cure rate. The double mastectomy lowers the chances of women getting a second breast cancer where they would have to start all over again with breast cancer treatment, but it doesn't affect these survival rates. Now, many women do prioritize the ability to lower their chances of ever having to go through the breast cancer diagnosis and treatment experience again, and that's totally fine. But women who make the decision for a bilateral mastectomy when they have one small breast cancer need to understand that their survival rates will be equal regardless of whether they go the lumpectomy, the single mastectomy, or the double mastectomy route.
Yeah, and see, that's a very important point because, if that's the case, then why would you do the biggest surgery? But that's people have to at least hear what the data says.
Yeah, got to be self-aware and sort out your own priorities.
Exactly. Now, the cases of breast cancer in women under 50 is going up for all women. It's not just Black women. So my question to you is why, oh, why have we been having this constant back and forth about the age at which a woman should start screening with annual mammograms?
Yeah, so I definitely have my own personal feelings about screening mammography, and I am a passionate advocate in favor of all average risk women getting mammograms starting at age 40 and continuing yearly thereafter. There are still some societies and professional organizations that recommend the women wait until they reach age 45 or even 50. Many organizations advocate in favor of women doing every other year mammograms instead of yearly. But the statistics are very clear that you will save the most lives if women start those mammograms at age 40 and continue them yearly. And if you do have high risk for getting breast cancer, either because of your family history or because of a past breast biopsy showing overactive breast tissue, then you might qualify to start those mammograms at even younger ages, or you might need to do what we call enhanced screening with breast MRI on a more regular basis. And women with dense breasts often need to have enhanced screening with ultrasound to supplement the mammogram or even breast MRI. So we do have a lot of ways to protect ourselves with screening, and I think that we have a long way to go before we are fully taking advantage of the screening modalities that are already at our fingertips.
Here's something the recommendation that I always used to chuckle about because, the biggest risk factor that we have for getting breast cancer, being diagnosed with breast cancer in our life is being a woman and living long enough to get it. Okay. And I was delighted when I finally, got to be the age. I'm almost out of the highest risk group now because I'm getting so old. But here's the thing about screening for older women. Okay, so I used to tell my patients when Medicare and, a lot of these will be dictated sometimes by insurance and they'll use the recommendations from the preventative task force. And they'll say, well, after 65, you don't need a mammogram, but every other year. And then after 75, they'll say, well, if your life expectancy is 10 years or less, you don't need one at all. And I used to look at my patients, I'm like, are you planning on dying in 10 years? Because if so, we can skip the mammogram. I said, but if you want to be here, let's go ahead and get one. I mean, that never made any complete sense to me.
Yeah, I am totally with you. And if only we could all look as fabulous as you. Every year you get older, you're getting more gorgeous, Sharon. No. I absolutely hate you for that, my friend. Right? But you raise a really good point. We are seeing increasing numbers of breast cancer in younger aged women. That is something that we definitely need to address through further research. And some of the steepest increases of breast cancer in young women we're actually seeing in the Asian American population, something that needs to be addressed through research. But for decades and decades and decades, the population-based incidence rates of breast cancer in young women have been higher in African American women. So we do still need to study the genetics of African ancestry to try to understand that better. So those are really important research issues related to the breast cancer burden of younger women and related to race, ethnicity. But to your point, as we age, it is true, every year that we get older, the risk of getting breast cancer increases. And older-aged women are a huge part of the productive American workforce. For a lot of reasons, we're seeing increasing proportions of older-aged women, women over the age of 60, 65, even 70, that are contributing active members of the workforce.
Exactly. I want you to, and we can't let you leave without being very clear to our listeners, what exactly are the risk factors? And when I say risk factors, that you have some control over to minimize your risk of breast cancer as you age. Can you share those with us, please?
Sure. Yeah. Probably the easiest way to keep these risk factors in mind is that many of the lifestyles that are good for cardiovascular health are also good for breast health. So a healthy diet, lots of fresh foods and vegetables, minimizing fat intake, exercising regularly, and avoiding obesity, minimizing alcohol intake. These are all very appropriate strategies to lower breast cancer risk. You also want to know more about your overall health to protect yourself from breast cancer. So know whether or not your mammogram has extensive breast density, indicating that you need to have other imaging studies such as ultrasound or perhaps MRI. Know the details of any past breast biopsies that you've had. It's always great news when you have a biopsy and you're told that it's non-cancerous, all benign, but you need to know the details of that biopsy. If you had evidence of overactive cells in your breast, you might be at higher risk for getting breast cancer in the future, and maybe you do want to consider taking prevention medication or go with enhanced screening. Some of these women will even choose a double mastectomy for prevention. So you do want to know the details.
Okay. So, I mean, the good news, and I think there is some good news, is that I want to ask you now about, I have a couple of lightning round questions, if you don't mind. And that is, I think one of them, I think we may have handled a little bit, but when you're talking about screening every year or every 2 years, what would you recommend? I mean, this is
Every year.
Average risk person, every year.
Yep.
Okay.
Every year starting at age 40.
Every year starting. Thank you.
Can I make one statement, though?
Yes.
I absolutely advocate every year starting at age 40, but everybody needs to remember that mammograms, ultrasounds, MRIs, none of them are perfect. And so if you do develop a danger sign, such as a new lump in the breast, lump in the underarm, bloody nipple discharge, changes in the skin appearance of the breast, I don't care if you had your last mammogram a week ago and it was normal, please seek medical attention. And to emphasize what you stated earlier, if you're not getting adequate answers from your primary care provider regarding those symptoms, go get another opinion.
Exactly. All right. Breast self-exams, yes or no?
That has a little bit of a nuanced answer. Mm-hmm. I do advocate in favor of breast health awareness so that women do notice if they develop any of the danger signs that I mentioned. But that monthly exam that we used to be really, really rigorous about recommending, it can unfortunately lead to unnecessary anxiety in a lot of women and can sometimes lead to unnecessary biopsies, because once a woman thinks that maybe something is different in her exam and she brings it to the attention of her physician, even if she's not really sure of whether or not it's something real, that often results in the scenario of you can't unring the bell and the woman might end up undergoing a biopsy unnecessarily.
Okay, and then I'm going to weigh in. See, this is why it's great to have second opinions here, because this is why they're opinions, right? And see, and my patients, and I have had, and again, and this is anecdotal, but obviously, in my patients, I have had patients with normal mammograms who've come back to me 2 and 3 months later and say, wait a minute, I feel something. Yeah. And it turns out to be breast cancer. And I always think, oh my God, if you had waited another year, and that was pretty much my sister who was diagnosed with breast cancer at 37, back in that day, she probably wouldn't have even qualified for a screening mammogram, but she had one. Then it was 35 as the screening, because this is back in the 70s. Yeah. And she found something and then went, and of course it was breast cancer. So I'm gonna go way into team breast self-exam. Yeah. All right.
I won't fight you on that one.
All right. A couple more, because I know we're getting close to the end, but I want to tell you, are dense breasts in and of themselves risk factors for breast cancer, or or people with dense breasts just it's more difficult to detect a breast cancer, which is why you need enhanced screening. Is there something about just breast density in and of itself that's independent of those?
Yes, yes. Dense breasts can absolutely obscure the detection of a breast cancer, but the breast density in and of itself, and here we're talking about mammographic density. We're not talking about a woman who notices that her breasts have a lot of lumpy bumpiness in them or a lot of thick tissue just on physical exam. Breast density as a risk factor for future breast cancer is related to what the radiologist is seeing on the mammogram, and they can quantify that density. And extremely dense breasts is a sign of overactive breast tissue that is more likely to develop a cancer in the future.
All right, last of our lightning round. DCIS, or ductal carcinoma in situ, which for our listeners who don't know what that is, that would be like pre-cancer, stage 0 cancer. And my question to you, because you're the expert, is it really cancer or is it not? I don't know what stage 0 is. It means it's like what?
Yeah. It is a form of breast cancer. Stage 0, denoting DCIS, indicates that these are cancer cells that cannot get into the bloodstream. And in the beginning of our conversation, we were talking about how the way that breast cancers can potentially cause metastatic disease is related to the fact that those cancer cells get into the bloodstream even before we've made the diagnosis. And they've already traveled to other parts of the body before we've made the diagnosis. That's what invasive breast cancers can do. The precancerous cells, or the DCIS cells, are biologically incapable of getting into the bloodstream, and so they are not able to travel to other parts of the body. Now, the $100 million question is whether or not all DCIS cells are necessarily obligated to turn into invasive cancer if they're left untreated for a long enough amount of time, if they're left in the breast for a long enough amount of time, or are there some that can regress or perhaps stay stable over the woman's lifetime. And this is why we do have some very exciting research studies underway to try to figure out if we can precisely characterize these DCIS cells and figure out which DCIS cases can be managed non-operatively. But right now, we do not know the answer to that question. So for today, patients with a diagnosis of DCIS do require treatment.
Okay. What are the trusted resources that you would, or someone who wanted more information about the more aggressive types of breast cancer, such as the triple negative, where can they go for more information on that?
Well, I would love it for anybody to reach out to me, especially if they're interested in information related to triple negative breast cancer and risk of African ancestry. And our work involves working on the continent of Africa. But for other resources that are widely available publicly on the internet, the American Cancer Society provides very reputable information. There's a wonderful organization called the Triple Negative Breast Cancer Foundation. Susan G. Komen, the Breast Cancer Research Foundation. These are all fabulous groups that provide reputable information regarding all different types of cancer, breast cancer in particular, breast cancer research, and triple negative breast cancer.
Fantastic. And we will make sure that we include information in the show notes of how to get in touch with you, because I think that is I cannot commend you enough. We need more research and we need more information, and we've got to get people to volunteer so we will be able to answer some of these questions that you have been trying so hard to do so over the past few years. As we leave, I want to ask you, what is the important takeaway that you want our audience to have from this conversation?
Well, I think that you've done a beautiful job of stressing the value of screening and breast health awareness. I do also want to continue stressing the importance of research, especially when it comes to understanding some of these variations in breast cancer burden related to race, ethnicity. Through our research looking at the breast cancer burden of women on the continent of Africa, we have indeed identified genetic markers associated with our Western sub-Saharan African ancestry, which we got through the transatlantic slave trade, of course, several hundred years ago. But we are identifying genetic markers associated with African ancestry that are linked to the development of triple-negative breast cancer. We need more research to understand these markers better, because these markers and others, and research understanding the immune system, the immune landscape of the breast, these are all really critical avenues of research to help us treat cancers, breast cancers more effectively by being able to enhance our own body's ability to fend off a cancer. And probably these research avenues will take us down the path of preventing breast cancer.
Outstanding. Dr. Newman, I cannot thank you enough for being here. You and I have been talking about this conversation for a very long time, and I'm so glad that we were able to make it happen. It's time for the last part of the show where I give you my doctor's orders and leave you with takeaways from today's conversation. Number 1, know your family history. You should be screened for genetic variants if you have 2 or more first-degree relatives, and yes, men can get breast cancer, or multiple generations of breast cancer in younger women. Having no family history of breast cancer does not mean you are not at risk. Number 2, start screening at 40, earlier if you are at high risk. I know the current recommendation is that women don't need to do monthly breast self-exams, but do it anyway. Number 3, there are things you can do to minimize your risk. Watch your weight, drink less alcohol, and exercise regularly. And last but not least, number 4, don't let the fear of breast cancer get in the way of regular screenings and checkups. Remember, over 90% of women diagnosed with early stage 1 breast cancer will live a normal lifespan. For more details and links, be sure to check out our show notes for the episode. Keep joining in each week on YouTube or wherever you find your podcast as I break down complex medical issues and leave you with expert advice. If you enjoyed the show, follow us so you never miss an episode. And if you like what you hear, leave a review. Until next time, take care.